there will be 5 questions. Haven't you earlier distributed this? I sent it to you, the batch rep. Huh? Sorry. Oh, yeah. Group again. So you will be getting it. Right. Can somebody read the first question? Okay, I'll read it. A 35-year-old patient was found to be unconscious on the road and was brought by the police to the hospital. On examination, he opens eyes to command, extends his upper limbs and lower limbs to pain, and incomprehensible speech. There was bleeding from mouth, but there were no signs of external injuries. Tone of the limbs were symmetrical. There was no papilledema. Okay, that's the first question. You all are hearing, I suppose, and you are seeing the question.
Yes, sir.
Right. Okay. We'll go to the second question also, because we are going to do it in a different way. Second, I am going to, if possible, I am going to divide you into 5 groups, and then 5 groups can discuss the question for about, say, 5 to 10 minutes, and then we will gather and discuss the one by one, right? Okay. Now for the group 2, I am going to give another scenario. A 75-year-old unmarried gentleman was normal when he had a drink with a friend at night. The next day morning, he was found to be unconscious. There was no evidence of vomiting. On examination, he had alcohol smell and pupils were pinpoint. He opens eyes on command and moves all 4 limbs on command. He was talking slowly, but the speech is understandable. He had passed stools on the bed and was sweating profusely. There are muscle twitches all over the body. The BP was 90/60 and the pulse rate was 45 beats per minute. That's the second scenario that we are going to discuss. And hopefully for the group 3, we are going a different scenario. A chronic ethanol abuser is admitted with confusion. Group 4, yes. Group 3. Did I say the group 3? Okay, I'll tell the group 3. 54-year-old man was admitted with rapidly progressing drowsiness over the last 3 days. He had mild fever for 3 days and had epileptic seizure the day before admission. On examination, he opened the eyes spontaneously and answers given for the questions were not rational. He moves the right arm on command. There were no neck stiffness or kerning signs. The optic fundi were congested. He had mild weakness on the left upper and lower limbs. Okay, that's a scenario 3. And scenario 4 is this patient with chronic ethanol abuse admitted with confusion and progressive left-sided weakness over 10 days. On examination, he was slightly febrile. He opened the eyes spontaneously and the answers given to the questions were not rational. He moves the right side spontaneously. There was spastic left hemiparesis and upgoing plantar response. And for the group 5, I am going another one. A 45-year-old patient with diabetes mellitus is admitted with features suggestive of urinary tract infection. His sleep was disturbed during the hospital stay, and on the 3rd day, he was found to be drowsy in the morning. He opened eyes on command and his words are incomprehensible. He moves all 4 limbs spontaneously and his optic fundi were normal and there were no focal neurological signs. Did you all hear the questions?
Yes,
right?
sir.
Okay. Now, um I am going to break you into 5 groups, okay? And those 5 groups can communicate with each other, uh, and discuss. And can somebody type out from one each from the communicate one who is going to communicate with me can type out the answers. All right. Yeah, group breakout room one. Hello, what is your problem? I think you can answer in the same sheet and send. We can share it also. Just start typing out the questions. So one group has to type out questions only for one question, right? Otherwise, there won't be any time. I have to now open all the rooms. I am going to open all the rooms.
හරිනේ.
ඉතින් අපි ආපහු ආවා. හරි. ඒ කියන්නේ දැන් අපි ලියන්න හරි මොකක් හරි කරන්න වෙනවනේ.
ටයිප් කරන්නේ කොතනද?
chat
I am with yes. No, I think you can edit this one. Just try to answer the questions. I'll type it on this one. Just I think you can just can you can.
In the document. Okay.
Google Doc, yeah. Have you got the question?
Yes, sir.
Yes, sir.
Right.
Sir.
Now just for me to check, just type out some answers and share it. You tried the taxes. Okay, that's a problem. So yeah, put it in the chat box and put your group number.
Group 1, sir.
Right. Put the group number and ask in the chat box. Right. Write in the chat box.
Okay, sir.
Okay.
Okay, I will join the other group.
Sekian.
මේ කවුරු හරි එක්කෙනෙක් ටයිප් කරා නම් හරි නේද?
පියුමිලා ටයිප් කරා.
ඔව් පියුමි ටයිප් කරා.
question එක දාන්න වෙන්නේ.
Group 1, have you sent can you share the answers? Have you written the answer or have you sent it in the chat box? Okay, in this patient, you have it in the chat. Okay, you can put it again. Right, share it. Yes, what's your problem, Tilina?
No, it's a mistake, sir.
Oh, okay, right. Oh, your screen sharing. I'm sharing the screen. Do you see? I had to move that away. Okay, because we have another meeting, we will quickly discuss this. Group 1, ready? While if you can type and share, that's fine, but we'll discuss.
Okay, sir.
What is the GCS of this patient?
7.
Yeah, his eye opening on command, that is how much? 2. Sorry, it's 3.
3, sir. 3, sir.
3, correct, yeah. Extension of the arms?
2.
2. And incomprehensible?
2.
7, correct, yeah. For this patient who was found to be by the side of the road, what are the differential diagnoses that you would consider? He was just found by the police. Can anybody answer? I can't see your answers.
We took metabolic causes like hypoglycemia and hyponatremia. And then
okay.
This may be postictal drowsiness.
Following a seizure, okay, good.
and he is maybe under influence of alcohol or drugs, and
Intoxications, okay.
and we thought this might be head injury following trauma.
Hot traffic accident. That's the most likely, probably. Okay. And okay, but your hyponatremia may not be an appropriate answer. Hypoglycemia is possible because sometimes while they are walking, they can get hypoglycemia and suddenly fall. But hyponatremia is a process where you don't get hyponatremia suddenly. They will have they will go to slowly drowsiness, confusion, and then only they will be unconscious. So hypoglycemia is correct. Seizure and can somebody answer that?
Sir, we couldn't hear you.
This says the internet connection is unstable, they say. All right, okay, good. What are the investigation that you would do? Investigations? Are you giving no answer? Or type it out then.
CBS
Very good.
and
Capillary blood sugar.
full blood count.
Why full blood count? More relevant investigations. Now when you are answering, you have considered some differential diagnosis in this context, in this situation, and you will get more marks for the appropriate investigation. Now, if on admission, more important things will get more marks, right?
Yeah. CT scan.
Okay, very good. CT scan. Contrast enhanced or non-contrast?
Non-contrast.
Why?
Because if there's a bleeding, the problem.
There's trauma, head trauma,
Yeah.
and to look for ICH, that is better, and this patient is unconscious, so non-contrast is relevant. Any other investigation? Yeah, not sure.
ECG?
ECG may be relevant here. Still, the patient may have had, that we could not discuss earlier, the patient may have had a myocardial infarction or arrhythmia and may have just got collapsed. That's possible, and then injury subsequent to the thing. That's good answer. What about EEG? What about EEG?
Yes, sir.
Yeah, because we are suspecting epilepsy also as one of the differential diagnosis. Okay, and then on admission we might ask what signs you do look for, so that the mucosal injuries will be relevant for a seizure, and external injuries may be relevant for trauma, and the alcohol smell or smell of the organophosphate or other poisons. So those things also will be relevant. And the history, there may be points in the history that you would take, like whether the patient is on insulin for diabetes and so forth, right? Until the diagnosis is confirmed, what actions would you do? What other things would you do on admission apart from checking blood pressure, pulse, and all that? From the management point of view, your ABC? Who would answer that?
You have to approach the patient in ABCD approach, and first you have to assess the airway and look whether it's patent. And since this patient's GCS 7, you need to intubate the patient.
Maybe, yes.
And give high flow 100% oxygen.
Very good.
and then connect the patient to monitors and check blood pressure, saturation, and pulse rate.
Good.
Um,
Okay.
and then you have to insert cannula
Blood, and you have to check the blood sugar, and then blood sugar, correct the blood sugar if there is any issue. Okay. Right, go ahead. Yeah.
and insert two white bore cannulae and take blood for other investigations, and give depending on the patient status, you can give relevant drugs, and you have to give normal saline bolus.
Why normal saline bolus?
If the patient's blood pressure is
Low, right?
low.
Okay, depending on the situation, there may be other actions. I mean, the specific management of each conditions, it will take a long time, so we'll skip it. But we'll go to group 2. Group 2, you are listening? Group 2?
Yes, sir.
Right. What do you think the GCS of this patient is?
14 out of 15.
I'll just check. Oh, it went up. Alcohol and okay. You open size on command. That's how much? That's 3. Move all 4 limbs on command. That is
6.
That is not 6, no? On command, but that is 5, isn't it? And he was talking slowly, but speech is understandable. It's 13. I'll right. I'm just trying to. Right. What's the next question? Yeah, the motor response, I don't know whether you can see. Yes, obeys commands. Yeah, that's 6, correct. Yeah. Correct. So it's okay. Now, do you hear me?
Yes, sir.
Right. What's the second question? Similar type of a question. Are you there?
What are the differential diagnoses?
Yeah. What are differential diagnoses for this patient?
Alcohol poisoning.
Okay.
Alcohol withdrawal fits.
Fits. There's no. There are okay. Fits, but what we're asking is the patient was unconscious. No, we haven't seen the fits. So what could have happened? One thing is alcohol intoxication. That's your first answer, was it?
Yes.
Yeah, that is correct. Patient may have been overdosed with alcohol and maybe drowsy. Any other thing?
Hyperglycemia?
Hypoglycemia is correct. Okay. But that is generally for an ethanol abuser. But have you read the question? He has alcohol smells, true, but pupils are pinpoint.
Opioid.
Yeah, pinpoint, and there's profuse sweating. Blood pressure was 90/60 and pulse rate was 45. Muscle twitching. What do all that indicate?
Opioid poisoning?
Yeah, opioid or something else. What is
organophosphate poisoning?
Organophosphate. All these are cholinergic crisis, features of cholinergic crisis. So it is very likely to be. So although there are many possibilities at the beginning, when you read the question, you have to narrow down the differential diagnosis, right? So in this patient, hypoglycemia may be considered, but the most likely is either organophosphate poisoning or any other thing if the muscle twitching and sweating is not there. And if the blood pressure was a bit high.
Heroin?
No, heroin also will cause pinpoint pupils, but not really the other features.
Pontine hemorrhage.
Very good, very good. Pontine hemorrhage or mainstem hemorrhage. Those are the two most likely diagnoses, and we give marks only for those two. Because others, although they are possible, when you consider the context, everything, it is organophosphate poisoning is very likely. And this not only can come as an SCQ, it can come as your best response MCQ also. In fact, this was given as best response MCQ earlier. Right. So you know how to manage in admission the similar way, and the specific management of organophosphate poisoning. To save time, you all can read that. Okay. And you must know how to manage if it's a brainstem hemorrhage also. Any question from group 2 or any others? Right. We'll go to group 3. What is the GCS?
It's 14, sir. 14 out of 15.
Open eyes spontaneously. Answers gives the questions were not rational. Yeah.
Yeah, it's confused.
Yeah. And moves right arm on command. Yeah, 6. Yeah, 14. There was neck stiffness. There was no neck stiffness or coning signs. Optic fundi were conjectured. He has mild weakness on the left limb and left upper and lower limbs. So what is the most likely diagnosis here?
Infective causes like viral encephalitis.
Very good.
And chronic meningitis caused by tuberculosis.
Okay, but where the history is 3 days. With that, would you consider, with 3 days, would you consider chronic meningitis, tuberculosis?
No, sir.
With 3 days and 3 days, fever and focal signs, what is the most likely diagnosis?
Viral encephalitis.
Any other thing?
Yeah.
What about abscess, cerebral abscess?
Yes, sir.
So can it be as this patient is having mild fever? If it was an abscess, there should be swinging like fever.
That is theoretically, especially in peripheral abscesses, you get very high fever. But even mild fever can occur with cerebral abscess. And sometimes they may not show fever occasionally, especially patients with diabetes and all, immunosuppressed elderly people, they may not have. But fever and a focal signs within 3 days, first consideration is whether it could be abscess. That has to be excluded. Of course, it can be for encephalitis with focal signs also. Those are the two most appropriate diagnosis for this patient, right? Now, infarctions or strokes are unlikely because it's progressing over 3 days and there's fever. Okay. Correct?
Yes, sir.
Right. So if this patient comes to you, consider that you have done all these basic investigations, blood sugar and other thing. What is the other important investigation?
Non-contrast CT.
Why non-contrast? What is the best if you are suspecting a cerebral abscess? Yeah.
Contrast CT.
Yeah, this is a common mistake done by many, because if the patient needs a contrast enhanced CT, and you can ask for an urgent contrast enhanced CT, because sometimes early abscesses can be missed on a non-contrast. And if you do a non-contrast, then again the ward people has to do another contrast enhanced CT. As much as possible, if there is a possibility, you must do contrast enhanced CT. What other investigation would you arrange? Apart from the, okay, and can focal signs be due to hypoglycemia?
No.
No.
Well, hypoglycemic attacks can cause focal, sometimes they can cause focal signs. But in this patient, with all the physical signs, it's hypoglycemia is not considered as the most likely diagnosis, right? Okay. Now, apart from the CT scan, what other investigation would you do?
EEG.
Why EEG? So it's for structural lesions, EEG is not very useful. Cerebral abscess and all, EEG is not very useful. Sometimes if the patient presented with a drowsiness or maybe seizure, we do EEG and then see focal signs which are compatible with focal lesion, but EEG is not a accepted answer for this type of a patient. This patient, right. This patient, of course, they had an epileptic seizure before, so EEG can be justified. But more now, if this is a cerebral abscess, what are the other important investigations?
Cardiac echocardiogram to see the vegetation.
Okay, yeah. One thing is you have to look for causes of cerebral abscess. That's one thing. And how are you going to treat this patient? If the cerebral abscess is confirmed, how would you treat this patient? What is the final specific treatment for cerebral abscess?
Antibiotic with hyperbaric oxygen.
Hyperbaric oxygen is wrong. Of course, definitive treatment would be we have to do a neurosurgical referral. But before that, you have to start antibiotics. What antibiotic would you consider?
It depends on the where the abscess is, because
yeah, we have to do cephalosporins, and in cerebral abscess, in addition to this, we will be giving metronidazole also.
Metronidazole.
And any other drug? If there is a lot of cerebral edema, and when you start antibiotics, you can start dexamethasone as well, or mannitol. Mannitol, yeah, if the patient is very drowsy, yes. Somebody said hyperbaric oxygen. What is that answer? From where did you get that? No, we don't give. Hyperbaric oxygen is given for patients with, this decompressive illness and all, right? So,
sir, what about giving 3% sodium chloride?
No, that is given only if there is. No, it is given only if there is a hyponatremia, and in some cases of cerebral edema, you give that. But in this patient, GCS was 14, and giving 3% 3% saline will cause more problems with hypernatremia.
Can we give steroids?
Yes, steroids in the sense because if there's cerebral edema, you can, once you have started antibiotics, you can give dexamethasone IV just to reduce cerebral edema because that will improve the symptoms. But so the correct answer would be I'll start antibiotics, ceftriaxone and metronidazole, and maybe dexamethasone, and then refer the patient urgently to the neurosurgical treatment. Understood? Any other questions?
Thank you, sir.
Okay. Group 4. Right. What is the GCS?
I open in spontaneous 4 and answer not rational is second 5.
Okay.
And step when there's moments in spontaneous, can we take as 6 motor component?
6, yeah, 6.
Then GCS is 14 out of 50.
Good.
And what is the diagnosis? As differential diagnosis, we took subdural hematoma with the trauma. And there can be Wernicke's encephalopathy or
Wernicke's encephalopathy. Generally, Wernicke's encephalopathy, when it is very advanced, you can get confusion and drowsiness. But generally, Wernicke's encephalopathy is a syndrome with eye movement problem, nystagmus, cerebral ataxia, and confusion. So other features are not mentioned here. Okay.
Okay, sir.
Right, because when you say he moves his right side spontaneously and all that, which means, and when we say there's a left hemiparesis with upgoing plantar response, and then if there had been any other eye movement problem, we would have mentioned it there, isn't it?
Yes.
Right. So out of these things, most likely in ethanol abuser, and it's a weakness progressing over 10 days. So what are the, somebody mentioned subdural hematoma. That's correct. Anything else? But fever, is it a feature of subdural hematoma?
No, so this is slight fever.
Slight fever, but that's febrile now, we have mentioned. Okay, so
cerebral abscess.
Cerebral abscess. What type of cerebral abscess? Now earlier, when the 3 days history, you mentioned tuberculosis. I said it's unlikely. With 10 days, is it likely?
Yes, sir.
Yeah. Generally, they say tuberculous meningitis, at least there will be about history of more than 10 days. You have to consider tuberculous meningitis. That is what is given in the book generally. So, especially when they say 2 weeks, you have to consider tuberculosis because there is a focal neurology of spastic left hemiparesis, right? Which means the problem is on the right hemisphere. And with fever, it should be, so in an ethanol abuser, SDH need to be considered. I totally agree. But considering all the possibility, all the information given, out of the two, most likely would be tuberculous meningitis. And it's very important for you to understand that in your MCQs, because we will be asking the most likely in that situation. So they will ask the most likely diagnosis or the investigation that you do and different types of things. But first you have to identify what is the most likely thing in here. So out of the two, SDH also will give half marks, but only tuberculous abscess or tuberculous meningitis will get full marks. Okay. So the additional features in the history and examination, you know what to ask for about contact history, the sweating, night sweating, evening pyrexia, loss of weight, constitutional symptoms, contact histories, and so forth. Investigation. Again, you will be doing all these routine investigations like capillary blood sugar and all, but in the investigation that would confirm the diagnosis. What investigation would you arrange?
Lumbar puncture should be arranged.
Oh. Do you do lumbar puncture for this patient with the focal signs?
Oh, no.
So what's investigation? First do. First that to do.
NCCT.
NCCT or CCT? If it's a tuberculosis meningitis?
CCT.
CCT. So because it is very important, in the questions, when you are reading the answers, we will be asking, we will give only one line for you to answer. But that one line, you have to write the appropriate answer. If you just say CT, we might not give sometimes. CT brain, we'll give 5 marks. Contrast enhanced CT brain, we'll again give full marks. But if you say non-contrast, that of course we will discuss that in the panel earlier, and probably we will give 5 marks, right? Out of 10. The management of TB meningitis, you know, right? So we are coming to the last question. Group 5, are you listening? Group 5?
Yes.
Group 5, can you hear me? Yeah, Vajit, yeah. Vajit, you have a problem? Connection is not poor. Connection is poor, is it?
Sir.
Yeah. Chat, there is a chat. Can you hear me? Can you all hear me? Group 5?
Yes, sir.
All right. What is GCS?
11.
See, we'll see his, he opened eyes. Words are incomprehensible. So 3 plus incomprehensible?
2 plus.
3, isn't it? Oh,
yes, 3 plus
3.
2 plus 6.
And volumes, yeah. Okay. So what are the differential diagnoses for this patient?
Delirium.
Okay.
And hypoglycemia.
What are the keywords in this question?
There's no focal neurological signs.
Okay.
And
context?
Has a urinary, he's a DM patient and
don't say DM, diabetes
mellitus patient, and has urinary tract infection.
Right. So patients with a diabetes mellitus with an infection, and then he was found to be unconscious. So there are two things. One is the causes for a patient with diabetes mellitus, the causes for drowsiness. That's one aspect. The other thing is patient with an infection and inward the causes of drowsiness, right? Okay. So what are the possible differential diagnoses? So you can
delirium.
take one.
Delirium.
Okay. Can be delirium, okay.
And hypoglycemia.
Hypoglycemia, correct. Anything else?
Septic shock.
Good. Septic shock.
Or uremic encephalopathy, because this UTI can cause to acute kidney injury and causing uremic.
But it is unlikely, isn't it? I mean, we have not said that patient has uremia earlier, and that's very low down in the list and will not probably get marks for that. But
and
there
relapse,
are more.
Relapse of psychiatric illness?
I have not said that this patient has a psychiatric illness.
Yes, but if he has past history or...
no, I have not mentioned. So all those are possible, but try to give answers which are more relevant. We may have decided on 2 or 3 answers which are very likely in these cases, and we will give, for those ones we will give full marks. Then there are things which are unrelated but still little likely, but for those also we will give some marks. But saying that the patient may have had diabetes mellitus, then the patient may have had an additional infection. That way you can go on telling about the things. So that will not be considered. Any other thing that can occur with urinary tract infection? Any other metabolic cause to make the
TK.
Yes, ketoacidosis. Yeah. Only thing is ketoacidosis, early ketoacidosis will not make the patient very drowsy because patient will be having dehydration, and at very late stages only the ketoacidotic patients will be drowsy. But any other thing? Non-ketotic or hypersmolar hyperglycemic state can cause drowsiness. Okay, anything else?
So uremic encephalopathy?
No, somebody answered, but we didn't accept it because this patient, we have never mentioned that it's a uremic. I mean, just a urinary tract infection will not just push them into uremic encephalopathy. Uremic encephalopathy will occur after advanced uremia. No? So before that, the patient could have had uremia. So this uremic encephalopathy is not accepted answer. Somebody answered it earlier also. Any other thing? Any other metabolic derangements? We discuss hyperglycemic states. We discuss hypoglycemia. With a UTI, can you get any other derangement?
Hyponatremia.
Very good. Hyponatremia due to SIADH. They can get electrolyte imbalances. Right. In this patient, there is another clue here. His sleep was disturbed during the hospital stay, and on the third day he was drowsy. What could have happened? Any other thing?
Hepatic encephalopathy?
No. Hepatic encephalopathy is very unlikely, no? That way, anything it could be. You are thinking that the reversal of sleep pattern?
Yes,
No, it is not relevant. We have to talk about this context.
Patient and infection.
Infection. She already has an infection, sepsis and septicemia and delirium we have discussed. Can it be anything to do with drugs? What would have happened when the patient is disturbing at night, or the patient is disturbed and sleep is disturbed? Then what would the doctors do? The doctors would have given some sedatives for him to sleep. Likely, unlikely? Hello?
Yes, likely, sir.
Yeah.
Sedatives.
Yeah. So there are several possibilities, but hepatic encephalopathy is extremely unlikely. Uremic encephalopathy is extremely unlikely. If it is hepatic encephalopathy, we would have given more features that he was disturbed at night, but during daytime he is sleeping. But here he has been, for 3 days he had been sleep disturbed, and doctors would have given some drugs. So those are the possibilities. Why I included this is that you should not be confined to one possibility, but you have to consider all the realistic possibilities. In this context, you cannot add things or imagine things and give answers, and those will not be given marks, right? Okay.
Okay, sir.
So the management depends on your differential diagnosis, and what do you feel about this discussion? Then there were a few questions that you had sent. If the patient is agitated, IM haloperidol to calm down the patient. But my general thing is, if the patient is restless, I give benzodiazepine. I know haloperidol is given in the ward, but problem with haloperidol is it can lead to extrapyramidal side effects, and the next day you may be thinking of, okay, this is a patient with drowsiness and extrapyramidal signs. So for that reason, I first try with the benzodiazepines. Of course, if the patient has hepatic encephalopathy or something, you cannot give it. Somebody has given the last question, delirium. Yes, that is one of the diagnoses. and sepsis. So you have to do blood cultures and treat the sepsis and control the delirium with maybe antipsychotics, maybe with benzodiazepine. Alcohol withdrawal is not relevant here because we have not tell the patient is ethanol abuser. Okay. Then somebody has asked whether whether hold on, how to decide on NCCT and CECT. Are you listening? Are you listening? Yes.
Yes, sir.
Yeah. It's very easy because if the patient has trauma, or if the patient has a stroke, you are suspecting trauma or stroke, you do NCCT. In most of the other situations, you have to do CECT. Strokes, seizures, those things, no point doing a NCCT unless there's a contraindication like uremia, where you cannot give contrast. You do NCCT. Sorry, CECT. NCCT is only for trauma and for strokes. In other situations, if there's a contraindication for contrast media. In such cases, in a developed world, I don't know whether they are developed or not now. Anyway, if you have better facilities, you might do MRI scans, but you know, it's difficult for us to do MRI scans in our setup that quickly. Any other question? There was another question. Somebody asked whether it could be AKI. In the fifth question, it is, well, it is unlikely. But one can say the infection may have precipitated pre-existing renal impairment, but we have not mentioned about the renal functions in this one. We may not give marks for that. But because there are many better answers before considering AKI. Any more questions? Did you all enjoy the session?
Yes, sir.
Yes,
Is it better than just
Yes, sir.
me giving a lecture, or would you like this?
Exactly, yes, sir.
That's better, sir.
Better.
This one is better, right?
Yes.
Okay. If your comments and things, I want to have a poll, but there's no time to build it up. If possible, I will make a poll, but you can send it to my email address. I have given that. I'll put it again here. My academic email address. Right. Send comments to this one. Anyway, I'll try to make a poll. Disconnect lah, ne? ruh.ac.lk. Oh. Just to see whether it works. Is this a statue? No. Oh, correct. just wait for few minutes. I will send you a poll.